Good afternoon, everyone. My name is Sufanah Alqahtani. I'm a cardiovascular technologist in Johns Hopkins Aramco Healthcare. First of all, I would like to thank the GIS CVP innovators for giving me this opportunity to introduce my topic, Structural Heart Coordinator. In my topic, I have sectioned it into 4 sections. First, I will talk about establishing the program, then the pre-assessment phase. After the patient is confirmed for the procedure, we will move on to the pre-procedural phase, and then the post-procedural phase. When it comes to establishing the program, the need for a structural heart program is volume-based depending on your hospital. So whether you need a structural heart program or you need proctor-guided cases depends on how many patients you have in your hospital needing structural heart procedures. Second of all, once you decide that you need a structural heart program, you need to involve your heart team, and you need to involve the percutaneous versus surgical decision-making into the heart team pathway. After that, you have to communicate the needed protocols for the new procedure to your hospital departments, whether you need dental clearance, whether you need anesthesia clearance, whether you need to establish CT protocols in radiology or TEE protocols in your echocardiography department. You have to communicate these needs to the hospital departments. After that, you have to assign a valve procedure coordinator as your point of contact between the patient and the institution's departments. Usually, you will need a main coordinator and a backup coordinator if you have a structural heart program. And last but not least, you have to obtain the required protocols, staff education, materials list needed for the procedure from the vendor. So after you have this program and you have your patient list, you are in your pre-procedural assessment phase for your patient. As a coordinator, you have to assess 2 different elements. You have to assess the eligibility for the patient, and I will talk about it in my next slide, and the urgency for scheduling this patient. Regarding the urgency, you have to have communication with your operator. He will decide the priority for scheduling for which patient to start with. Regarding the eligibility, this is the main duty of the valve coordinator, and these are the key elements that the patient needs to go through, sort of your checklist to complete, to confirm that the patient is eligible for your procedure. Mainly, you will need dental clearance, you will need a cardiology clinic visit where you will establish the education for the patient. The physician will determine the benefits and the risks for the procedure. If you have any assessments like a frailty assessment, 5-meter walk test, things like that, it will be done in the cardiology clinic. You will need also a cardiac surgery consultation to determine what's best for the patient, whether it's going to be a surgical intervention or a percutaneous intervention. And when you decide that the patient has a better chance with the percutaneous intervention, you need to assess your backup plan or your bailout, if the patient will need a surgical bailout or just ECMO bailout. Another thing to assess is your valve assessment protocol. For example, if the patient is going for TAVI, he will need to go to radiology for CT TAVI. If the patient is for mitral clip, you will need to do your TEE assessment. And you need to make sure that the proper protocol is done in the department itself and send it to the vendor. After that, you will need your vendor feedback, and your vendor feedback will give you a good idea of what is suitable for this patient's plan specifically, whether it's your size or in your peripheral vascular assessment, which is your most ideal access for the patient. As well, you will need labs and examinations such as your blood work, your echo, your ECG, and your coronary angiogram assessment. You need also your anesthesia clearance, and you need to assess if the patient's condition needs him to be pre-admitted in your inpatient service, or if the patient can come in the same day as an outpatient through your day surgery department or your cath lab recovery department. Now, once the patient is confirmed for this procedure, you are in your pre-procedural preparation phase. This phase is usually between 1 week to 1 day before your procedure. These are the things that have to be completed at maximum a day before your procedure. The first and the most important thing is patient communication. The valve procedure coordination ideally needs to have his own business mobile or a business extension where the patient can have continuous communication between him and the coordinator. In that communication, you can explain the date of the procedure, whether the patient will be admitted or an outpatient, if the patient needs to stop any kind of medications, and if his fasting status. The next one is to prepare your bailout plan. Depending on the cardiac surgery consultation, the patient will either need a surgical bailout or an ECMO bailout. If you have a surgical bailout, you need to communicate to OR that they need to be there at the time of the procedure. And if there is an ECMO bailout, you need to communicate it with the perfusionist. Next is procedural supplies, medications, sterile equipment, and material preparation. All your materials, your sterile equipment, and your supplies need to be completely ready and prepared at maximum before the day of your procedure. After that, you have to assess and double-check the labs and results for the patient. If you see anything abnormal, such as low hemoglobin, high WBC, high creatinine, or anything like that, you have to report this to the operator because he might change some preparations or he might reschedule the procedure. After that, you have to prepare for complications always for any type of procedure, especially if it's a structural heart procedure. Keep your complication equipment with you in the room, whether it's IR equipment, snares, ECMO cannulas, valve balloons, or temporary large vessel occlusion balloons such as the CODA balloon. Additional preparations should be prepared when needed or communicated by the operator. Whether you need the access facilitation, your femoral access needs some help with peripheral balloons or with shockwave or anything before your procedure, we have to prepare it beforehand. Or if the patient needs concomitant right heart cath procedure with his structural heart procedure, or in cases of TAVI, he might need cerebral protection device, valve predilatation, or left main protection. Now, once the patient's procedure is done and will be transferred to the CCU or the cardiac ICU, the patient will mostly be handled by inpatient services and the staff physicians covering the case. However, the coordinator should ensure that all of these elements are done. Mainly the patient's education with his family. We need to double check the post-care instructions are given. And the access site has to be assessed. Labs and examinations such as echo, labs, creatinine, and everything has to be assessed. And we have to ensure that all the follow-ups are done and booked before the patient leaves, such as cardiology, clinic follow-up, cardiac rehab, and post-procedure medication plan. Now I'm actually done with the content of my presentation. This is just a future plan I have for the structural heart coordinators. This is just a very simple website that I have prepped. You can scan this QR code to discover it. This website is called Valve Prep. I have prepared this for the coordinators to try to kind of just summarize all of their lists in one interface. This interface, you can include which protocol you want, and this protocol will have its own pre-procedural checklist saved in your profile. And you have a references page with the TAVR checklist and your TAVR endorsement, as well as the brochures of the most commonly used devices in the Middle East. Thank you so much.